I'm Dan Pollier from the University of Colorado, where I direct the leukemia service, and I'll be moderating today's tumor board. And I'm joined by some of my colleagues from around the country, and I'll let them introduce themselves, starting with Dr. Kamdar.
Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado, and I lead the lymphoma program there. Glad to be here.
Hi, Tyler Fromm. I'm an assistant professor of radiology with appointments in both abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri, and I'm happy to be here as well.
Hi, I'm Michael Thurman. I am an associate professor at the University of Chicago, section of hematology oncology. I focus on hematologic malignancies and in particular leukemias.
A very challenging situation of acute lymphocytic leukemia, also called acute lymphoblastic leukemia, same thing. This is a case that is Philadelphia negative. So here we have a 21-year-old woman with a rapidly progressive diffuse lymphadenopathy who has a biopsy-proven T-cell ALL, presenting to discuss treatment options. So we're going to talk about how to approach a patient such as this. And I know, Dr. Kamdar, you're often, as a lymphoma expert, and someone coming in with diffuse lymphadenopathy, you're often involved early days because of assumptions about what this diagnosis is going to be. Can you give us just some tips on advice on how to work up a patient such as this most efficiently so that we can quickly get the right information? And specifically, how would you approach a lymph node biopsy in a patient like this?
So I think in a young female who presents with diffuse adenopathy, the first thing would be to get tissue. And the best way to get that would be an excisional biopsy. Of course, if an excisional biopsy is not able to be done in a safe manner, then a core biopsy would be fine. If this is a mature B cell or a T cell lymphoma, it's probably unlikely to be positive on flow on peripheral blood. But if it is an ALL, then it's likely that flow on peripheral blood would be positive. But from a lymphoma standpoint, from a mature lymphoma standpoint, I think excisional biopsy would be really the most important piece here. Once we get the excisional biopsy, as that continues to be worked up, I think a PET-CT is what would be recommended for most of the aggressive lymphomas. And a PET-CT with a diagnostic CT would be preferred, although that's not usually done.
And Dr. Kamdar, can you just maybe give some of our audience some advice on, I know, sometimes when I'm interacting with our colleagues in interventional radiology or surgery and requesting why it is so important that we get an excisional biopsy instead of a needle biopsy or a core, just so folks can have a good response to our surgical or radiology colleagues about why this is so critical, the excisional.
It's really important to understand that in solid tumors, an FNA is sufficient, and it's absolutely insufficient in the world of hematologic cancers. So FNA is usually something that we will not even look at, and we'll have to pursue a larger sample. In terms of a core biopsy versus an excisional biopsy, a lot of times there could be composite lymphomas, there could be transformed lymphomas. So in order to understand the morphology, in order to perform testing like flow, immunohistochemistry, followed by FISH, and in most cases these days, we also follow it up with molecular studies. And I think for that, sampling is really critical, because the best that we can do at this point to serve the patient is to really understand what diagnosis the patient has. So if for some reason we get a diagnosis of follicular lymphoma on a core biopsy, however, if a PET scan shows an SUV that's very high, I would want to pursue an excisional of the highest lymph node or the highest SUV lymph node, only because the follicular lymphoma piece and the DLBCL could then be completely seen in the entire lymph nodal excisional piece. So I hope that helps.
That's really helpful. And yeah, I think, we're often, just trying to make our case. We're not being difficult. That this is really important. This kind of information is critical in helping us make a treatment plan. And then this 2-month history of a rapidly progressive diffuse lymphadenopathy. Her performance status is 0, as good as it gets. She's 21, she has no pertinent medical history, no contributory social history. And here we go again, taking a family history. We see a mother with CML who had lymphoid blast crisis and had to get an allogeneic stem cell transplant. So, back to you, Dr. Thurman, on this. I mean, in some ways, it is possible to have a coincidental, history of a blood cancer within a family. And these are, we're talking now, we know that this is going to be a case of acute lymphoblastic leukemia, but hard in a pH negative one at that. But, when patients ask you, Dr. Thurman, how do you answer them as to knowing whether this is, something that the whole family should be concerned about, and what kind of screening should be done, if any?
Again, it's very interesting scientifically to try to see if we can identify potential mutations that are present in genes that are important for hematopoiesis. And in addition to the scientific interest that we have, it could have implications for finding donors if this patient ever were to go to transplant, and you would want to use a sibling donor who had that same mutation if it could be identified. I don't know of a specific syndrome where CML and T-cell ALL are involved in the same family, but this is really a new area, as you mentioned, and really something that we've only been looking at for the past few years. So I think it's going to turn out, when we look at these cases, that we're going to be able to find more and more variants that lead to genetic predisposition to develop leukemia and other blood cancers. And it's probably going to turn out to be true for solid tumors as well.
Definitely an area to keep an eye on in the very near future. So this patient is pancytopenic, leukopenic, neutropenic, anemic, platelets just at threshold for normal. And the bone marrow biopsy does confirm this key lymphoblastic leukemia, 50% of the bone marrow. You can see some of the flow markers there. And on the molecular panel, there's a Notch1 mutation, which we know is a common mutation in T-cell ALL. And Dr. Fromm, maybe you can take us through the highlights of the CT scan that the patient had performed.
Sure. Yeah. Here we have 4 selected images from a contrast-enhanced CT of the it's like the neck, chest, abdomen, and pelvis. In the upper left-hand image, we see a relatively small bilateral supraclavicular lymph nodes, a little bit abnormal in morphology, but not like markedly enlarged or anything like that. On the right-hand side, the upper and the lower images are showing similar kind of borderline enlarged or kind of prominent retroperitoneal lymph nodes. Nothing really to kind of write home about in isolation. But the lower left-hand image is the sort of most impressive of the 4, which shows pretty marked lymphadenopathy in the mediastinum, sort of involving the both sides, the sort of right paratracheal lymph nodes, prevascular lymph nodes, and we're told sort of in this case that there was no quote unquote mediastinal mass. And I guess one point I would make about that is that the sort of confluent lymphadenopathy versus mediastinal mass exist on a spectrum. And what one radiologist might call just lymphadenopathy, another radiologist might call a mass there. So I think it's important to kind of discuss in terms of what you're actually looking for in terms of management implications with the radiologist that reads the study. I think in some cases one might reserve the use of the term mediastinal mass for a lesion that is so large that it's kind of exerting mass effect on other structures, compressing the superior vena cava or the airway in a significant fashion. So I think it's kind of a spectrum, and the terminology is sometimes not precise here. Confluent lymphadenopathy versus a mass. I guess one thing I did want to say, kind of going back slightly to the prior discussion, we oftentimes see in patients like this who have diffuse lymphadenopathy that I read PET CTs, and I also do percutaneous biopsies, cores, and FNAs, and we'll see that both a core biopsy and a PET CT will be ordered at the same time, and we'll on the biopsy service we'll often say, okay, let's wait until this PET CT gets done, because oftentimes that information is very useful for us in deciding which lymph node to target, and we try to go after the site that's most FDG avid. So I guess that might be an interesting point to discuss, sort of what the practice patterns are at your institutions for that. But usually we sort of will request that the PET CT be done first, and we can sort of use that information in finding a biopsy site that's going to be highest yield.
Yeah, that's a great point, and that makes a lot of sense. And Dr. Kamdar, have you found that sequencing things that way is also ideal?
Absolutely. I think the initial CT will suggest lymphadenopathy, and then we will really try to get a PET CT first while arranging for a biopsy, and then really targeted towards the site with the highest FDG avid lesion. However, the truth is that it's not always possible in different hospitals, because there can be different policies. For example, some hospitals won't allow inpatient beds. And in that case, you just have to go with the largest mass, as at the same time, the safest one to biopsy. But thankfully, at least in our institution, for now, we are able to get inpatient beds and then target the biopsy accordingly.
Yeah, usually, just when these patients present, it's just very labor intensive to get all the information we need. And of course, like you said, the safety of the patient is also of primary importance, and knowing how to prioritize that is crucial. So, I mean, these are really tough cases. T-cell ALL is the least common type of ALL. So compared to B-cell ALLs, it's very uncommon. This would be considered, a 21-year-old would be considered an adolescent young adult or an AYA patient. And I think what we have learned from our pediatric colleagues is that treating patients in this age group, which really extends upwards into probably 35 and maybe even a little bit higher, is to treat these patients very aggressively with combination chemotherapy type regimens. And, I think there's a couple of different caveats here. There are some, in a 21-year-old, I think you could just treat them with a pediatric regimen, and many children's hospitals would take on a 21-year-old. And so I think that would be very appropriate to do. In the older age groups, like into the 30s, we have modified regimens of the pediatric combination chemotherapy protocols that we've toned down a bit for folks who are a little bit older. And I think that would be appropriate to consider here too. I think the prognostic significance of the mediastinal mass is less now in the setting of these combination chemotherapy regimens than it once was. So I think, whether or not there is a mediastinal mass, it was at one point a very important prognostic factor, but now seems less so because these therapies are quite potent and outcomes are fairly good, not anywhere as good as in our pediatric population, but quite good. Dr. Thurman, any different approach? Again, you're coming from an institution that really was one of the pioneers in developing AYA regimens. Any way you would regard this patient or differently, or?
I think, as you point out, T-ALL is relatively uncommon and has historically been difficult to treat. So first of all, if you could find a clinical trial for this patient, that I think would be the ideal first choice. Off protocol, we're typically using a pediatric-based regimen and the COG regimen and trying to incorporate nelarabine into the initial therapy, if possible. And for relapse patients, we definitely use nelarabine. But if in a newly diagnosed patient, essentially we would do, the COG ALL protocol with nelarabine. I think this is, these types of cases, since they're so rare and complicated, are best treated at a major center. It depends on a lot of factors, but a young healthy patient like this should do reasonably well with aggressive therapy.
That's I would say the same. And this is also a patient that we would hope to maybe even avoid a transplant in first remission. And if a patient like this achieved a deep response radiographically, and or if there was disease in the bone marrow, that could also be assessed. And there was no residual disease afterwards. This might be a patient you'd be able to cure with just chemotherapy-based regimens. So great. So just to sort of summarize, a 21-year-old with T-cell ALL has a rare condition, and one that we would treat aggressively with a pediatric-inspired or a pediatric regimen of a combination chemotherapy protocol, and clinical trial for something that this rare would be preferred, and especially to be able to maybe incorporate something as active potentially as nelarabine into a regimen like this.